Yeah.
Or you want me to use two?
Yeah.
Two of them? Or this one is at the right side. Yeah. Yeah. I think so. Thank you very much, and good afternoon, ladies and gentlemen. And thank you for coming to listen to me in such a short notice. I called you here because many of you have been frantically phoning me since the weekend to come and comment on the various issues raised in the media about the state of healthcare system of our country, specifically the public healthcare system. Yesterday, it was even worse. In fact, the general talk or the narrative, which is generally accepted as true by a lot of people, is about the healthcare system having collapsed. I called you here today so that I answer questions that you have, because many of you have raised the questions about this narrative of, or what has been seen on the TV screens or heard over the airwaves in our country. But before allowing you questions, I thought I should take the opportunity to say a few things, perhaps in the form of providing information, because it's also clear to me that perhaps some of the things have not been communicated adequately by the department. It is very true that and self-evident really, that the healthcare system is very distressed and going through very hard times. There's no question about that. The pattern of disease and hence the demand of healthcare has grown so exponentially that the system finds itself extremely overloaded. For instance, if you go back 2004, South Africa had 400,000 people on ARVs. Today we have got 4.2 million. It increased 10 times. And all 4 million are treated in the public sector. Only 200,000 million are getting their treatment elsewhere. But 4 million are carried by the public sector, meaning the number of people who used to go to our clinics between 2004 and now has increased tenfold. But this was not met by a concomitant increase in the number of staff or even the number of facilities and equipment. That doesn't happen really, because the increase of this tenfold increase happened within a very short space of time of that period, as I'm saying, of 10 years. So this has resulted in very long waiting times in most of the facilities, and of course the lowering of quality in others, in some of them. But has the system collapsed, really? Well, I'm not really here to challenge that, because I cannot, because I do not know the yardstick which was used to arrive at the conclusion of collapse. Because surely, I believe that healthcare systems are measured on some form of scientific yardstick to arrive at any conclusion. People just don't stand up and, in anger, announce a particular conclusion without having gone through some scientific process which must be acceptable to all. But as far as we know, this healthcare system is still able to provide treatment to the largest number of HIV-positive people globally. As I have already said, our HIV/AIDS program is the biggest in the world at 4.2 million people. In the next 24 months, we are poised to initiate an additional 2 million people. So in 24 months' time, there will be 6 million South Africans who are on ARVs, and we are ready to launch that on the 28th of June, that is this year. The Executive Director of United Nations AIDS Program and the Executive Director of Stop TB Partnership will move from Geneva to join President Ramaphosa to launch this. That program is not only about HIV and AIDS. We are going to screen 14 million South Africans in that program for HIV and AIDS. We are going to screen about 7 million for TB. We are going to screen about 7 million for diabetes. We're going to screen about 7 million for high blood pressure, and screen about 7 million for cancer, which I'll visit later. This Department of Health is still capable of doing that. Our public health system is still able to treat all patients who suffer from TB, all 300,000 of them who are on treatment. And you are aware that in South Africa, TB is only treated in the public sector and nowhere else. We are the first country in the whole world to scale up in the use of new TB diagnostic and early introduction of the latest medication for TB. As far as we know now, 40% of all gene expert cartridges that are used in the whole world are used in South Africa in the public health care system. We also know that of the total number of people globally on new treatment drug called betaguline, 60 of them globally are in South Africa with the treatment provided by us. In 2009, a total of 69,251 people died of TB in our country. This figure has dropped to 33,063 by 2015 already. This is more than 15% reduction. It did not happen on its own. It's because we put together a concerted plan and effort to make sure that we reduce the number of people dying from TB. I'm emphasizing TB because you are aware it is #1 killer of all infectious disease in the whole world. And you are aware that it has been regarded by United Nations as a global security risk. And so in September this year, there's going to be a high-level meeting in United Nations about TB, where heads of states from all over the world are required to go to New York to debate about TB, because it's #1 killer. That's why I'm mentioning it. That it used to kill 69 million people in our country by 2009, and we dropped that figure to 33 million. Through this treatment program and new diagnostics, in which we've by far #1 in the world. In 2004, or by 2004, a total of 70,000 babies were born HIV positive. This figure has dropped since then from 70,000 to below 4,500 now. We are still able in the public healthcare system to take care of 1.06 million women out of the total figure of 1.2 pregnant women. And to make sure that we are adequately taking care of them, we have registered them on a system called Mom Connect, through which we communicate with them every single week. Cumulatively since August 2004, when we started registering women on Mom Connect, we have registered over 2 million pregnant women. And out of this number, 1,620 lodged complaints against the public healthcare system that they were not happy about the treatment they received. But while these 1,620 lodged complaints In the same period, 15,440 sent messages of compliments that they are actually happy about the treatment we have given them in our public health facilities. And this information is unsolicited, obviously. So we do not really think that a collapsing or a collapsed health system can be able to do these things I've mentioned. But yes, we accept and are very worried by the extreme overcrowding in our hospitals. We believe this could have been much worse if we did not take proactive steps. Some of the hospitals commonly mentioned, which was in the news yesterday, was Tembisa Hospital. Yes, I went there at the end of May with President Ramaphosa. It is true that things are bad there. We went into the neonatal ward, which has been designed for 40 beds. And there were 70 babies there. And they tell us that it does go right up to 90. A ward designed for 40 babies carrying 90. That's overcrowding, is true. And the doctors told the president that an overwhelming number of them are not South Africans, are foreign nationals. So we are not only carrying a huge burden of disease from the country, we're also carrying a huge burden of demand for healthcare in our country from the neighboring states. You might remember that last year when there was a big story about a woman from Burundi who was supposed to have been refused treatment from Tshwane District Hospital, delivered at Park Station. One of the hospitals accused was Charlotte Maxeke, which was wrongly accused, of course. And they were saying we are xenophobic, we don't take care of foreigners. That was June last year. But in May, that hospital which was accused, Charlotte Maxeke, had delivered 700 babies. And 400 of them were not South Africans. And so we got completely surprised about them being xenophobic and refusing to take people from other countries, when actually it has increased our huge burden. We do accept and get worried about this overcrowding, as I've said, but we believe it could have been much worse if we did not take proactive steps. One of the steps we have taken is to decant patients away from clinics and hospitals. In other words, we have selected some patients which we think are stabilized and encourage them never to go to any hospital or clinic when they are just there to collect medication. Of course, when they are there with an acute disease, they will go. But there are lots and lots of patients, due to this high burden of disease, who just go there to queue for many hours to collect their monthly treatment. We have asked these patients to select pick-up points that are suitable for themselves, and will go and deliver the medicine there. As I'm speaking, 2.2 million patients in South Africa are no longer going to our clinics every month. They collect their medication on these pick-up points. This program is called the CCMDD, or Central Chronic Medication Dispensing and Distribution Program. We are poised to load 1 million more people on this system during this financial year, so that at the end of the financial year, there will be 3.2 million patients who don't need to go to our clinics. Those who have chosen the clinic as a pickup point, they no longer queue at casualty. They just arrive and go straight to dispensary. They've got a card, and when they arrive there, they found their medicine already packed. They just collect and go. We heard yesterday about the dramatic statement that our public health facilities have run out of medicines and theaters are leaking. Since yesterday, I've been phoning around to find out about these leaking theaters, because the theater which I knew were leaking was in KZN in October last year due to flooding. But we have taken over those patients who need theater care. to Nkosi Albert Luthuli, to Kindini Zulu Hospital, and to St. Aidan's. And we are busy repairing the theaters in King Edward Hospital, which is very old. I also remember a theater leaking in Mankweng very early last year due to floods. But now I've been frantically phoning, maybe information will come forth very soon about theaters which are leaking, but I've dismally failed to get that information from last year. But the issue of drug stockouts surprised us, because barring Northwest, with its very recent trouble, the concept of drug stockouts in our facilities, we thought it has long been solved, because in 2014, we launched a new technology together with the Vodacom Foundation. That technology is called SVS, or Stock Visibility System, which is helping us to monitor stocks in our clinics while we're sitting right here in Pretoria. And we do so every single week. We monitor that stock every single week. We don't even wait for a month. So this SVS is in clinics. In the hospitals, we've implemented what we call the RX solution. Our weekly monitoring for last week ends today. And the information we have today, for instance, if you look at ARVs, Eastern Cape is at 91.9% stock. For ARVs, for TB is at 85.4%. For vaccines is at 88.9%. I did not include other drugs, but the information is there. Gauteng for ARV, for instance, despite this huge burden of everybody migrating from province of Sade coming to Gauteng, but as of today, the ARV stock is at 96.1%, TB is at 91.6%, and vaccines, they are at 97.26%. In this issue of drug stock out, the lowest province is Limpopo, which is at 87.8%, 76%, and 85.3% for ARVs, TB, and vaccines, respectively. Even Northwest, which was in crisis as of today, have improved to 86.2% for ARVs, 75.8% for TB, and 81% for vaccines. I've chosen these specific drugs because a huge number, millions of South Africans, these are the drugs they are collecting in our hospitals. On our hospital dashboard, we also average 88% for the highest province and 70% for the lowest provinces, which are Limpopo and Northwest. We have a biggest problem of human resources, which we cannot deny. It will be very foolish for us to deny it, because after all, while sub-Saharan Africa carries 80% and more of all infectious diseases in the world, it has got only 3% of human resources for health in the world. And South Africa is not exempted from that 3%. We're part of that because we're in sub-Saharan Africa. So, but South Africa is very badly affected because of this huge burden. We have decided to enter the battle robustly, and I'm sure many doctors and nurses and health workers have complained about this issue. They are definitely correct, because it's one of the biggest problems we're faced with. But I must also confess that some of the shortages of human resources are truly self-inflicted, like what happened in Northwest, where they just stopped hiring people. But after placing them under Section 101B, we found huge vacancies which we can't explain or understand, let me say, not explain, but understand why so many vacancies were left unattended. And I want to announce that before the end of this month, we will have advertised the first set of critical posts in Northwest. We will advertise 223 vacancies. at the cost of 150 million rand. Most of them will be in clinical services. Our other problem is routing, which I said carries the burden from everywhere. I've made it known to routing that no matter how tough it is, we cannot afford not to fill vacant posts in health, especially those at the cold phase of delivery. We simply cannot afford. We will be cutting our supply lines, and so routing will fill a substantial number of posts, especially in teaching hospitals this year. The MEC for Health Dr Aaron Motsoaledi will give details on when and how are they going to be doing that. I'm sure she'll give those details in the next few days, not weeks, but very few days. We will also help KwaZulu-Natal and Gauteng with their radiation oncology backlogs, which has been in the news. This program to deal with cancer in South Africa, which has also exploded, will be launched early in August this year. Gauteng and KwaZulu-Natal will get 100 million rand between them to try and help them deal with cancer backlogs. You know what caused the backlogs in KZN. It has been in the news for quite some time. In Gauteng, it's out of no fault of their own. They are carrying all the former Transvaal provinces. They carry Limpopo, they carry Mpumalanga, they carry Northwest. And lots and lots of patients who are coming there are coming daily to Steve Biko and Charlotte Maxeke Academic Hospital, because those are the ones in Gauteng that deal with cancer treatment. We are also painfully aware of poor management skills in most of our provinces because of wrong employment practices, like appointing people in wrong places without them having skill. This has been a perennial problem which we've been trying to deal with and discourage our province from doing. But it is a problem. We are also aware of the negative attitudes of some staff members in quite a number of our facilities towards patients. As from today, as I'm sitting here, we are deploying 200 officials from head office. Some of them are managers, others are managers, but they happen to be doctors, managers, but happen to be nurses, managers, but they happen to be pharmacists. We are sending them to our provinces. I know that when I left, the Mpumalanga group have left. While we mentioned the long waiting times as brought about by high demand for health services, we also believe with good management skills and planning, some of these problems like waiting times can be markedly reduced. And we believe senior people from head office should no longer sit in their offices, must go to the ground and see why hospitals and clinics, for some reason or the other, are failing to put up good planning to deal with this huge avalanche of patients who are visiting our health facilities. We will see at the end of this month what difference it will make when senior people are no longer sitting at office but are in the facilities themselves. I am really prepared to answer your questions because I said I'm going to make a very few statements before I give you over to questions. So this is your time because I organized this event for you. Thank you very much.
Thank you, Minister. Now I'm going to take questions, colleagues. As you raise your question, please introduce yourself, the media house, and your question. The first question. I'm going to start this row. Number one? Maybe number one, number two, three, down this side, number four. Any other question, colleagues, before I'm going to take these first four hands, then we'll have the second round. Over to you, Adrian.
Good afternoon, Aldrin Sampier from ENCA. When you listen to Professor Makgobo, the Health Ombudsman, he paints quite a bleak picture on the state of health. Are you then disagreeing on the state of South Africa's health system, on what his assertion is that it could be on the verge of a collapse? And how often do you get to meet with him to deal with some of the complaints that he's receiving and how he has come to his conclusion, taking into consideration what you have said here? And the final one would be, what would your assertion then be of the state of South Africa's health system if it's not in a crisis?
Thank you, Adrian.
Good day, Sipho Sterman from SABC News. My question is similar to that of Aldrin, but I just want clarity on your side. So you're saying that the health system is not in crisis. This is despite, of course, we've had the South African Medical Association, which has spoken about deep-rooted leadership problems in the health sector. We've had the South African Committee of Medical Deans also speaking of a crisis. Earlier in the year, we've had EFF also saying that the South African health sector under the current government is worse than apartheid government. So you've had these sectors of society, political and within the health sector, saying that there is a crisis. TAC, that is a Treatment Action Campaign, they've also come through to say there is a crisis. So have you perhaps engaged with these sectors to understand their concerns? Thank you.
Thank you, Sipho. Yes, over to you, ma'am.
Hi, it's Catherine Child from Times Live and Sunday Times. Minister, it sounds like you're blaming patients. You're saying there's a huge avalanche of patients in Gauteng causing the cancer crisis. However, the machines at Charlotte Maxeke are 16 years old and keep breaking. They need to be replaced. There are vacant posts there that need to be filled. How is it the fact that there's so many patients at fault when there aren't enough doctors and there's broken equipment, and they've been asking for new equipment for a while? And then you say there's a huge burden of HIV. We know this, but with so many people on treatment, in a sense, there's less sick people in the hospital. They're not there dying.
Northwest, the case in Gauteng Oncology, Esidimeni, as well as the strikes. I mean, do you still believe that you are the right man to head the department? Thank you.
Thanks, Watle. I'm now going to hand over to the minister to respond to this. Watle, can you switch off your mic?
Adrian, I phoned Professor Makgobo. I'm not challenging him. He is the health ombudsman. Health ombuds are not news analysts or political parties or NGOs. They are a statutory body. The Health Ombuds Office is a statutory body which works based on certain rules and regulations and give reports. And Professor Makgobo gave a very scientific report and the methodology used on life is demanding. But on the statement he made, I wanted to know, because I didn't have any report, I really wanted to know by which study or through which method did he arrive at the conclusion. What he told me is that he meant if the present laws of the country are not changed urgently, there is an imminent collapse of the healthcare system. At least that's what he told me. The statement he made on TV, I did not see him personally. I was very busy on that day. I was phoned by people who were asking me about it, and that's why I contacted him. So I'm not challenging him. I just wanted to know the methodology, the measuring rod, which is used, because usually when statutory bodies mention this, they give figures and numbers and the reasons, but I did not get them really. So it's not a challenge, it's just a surprise for me. And that's why I phoned him to try and get clarity. And how often do we meet? I don't usually meet with Professor Makgoba because in the Act, the National Health Act amendment, Section 88A, which hired the Ombudsperson, he does send a report to Parliament, to me, after every end of term. My job is really to send in complaints if they come in, if they are not sent to him directly, or to phone him if I've got a question to ask. So we don't really have frequent meetings. Professor Makgoba is not working in an office that is standalone. He's working in the Office of Health Standard Compliance, which has got a board. So it is the board I meet quite often. And I met them, I think, sometimes in March this year. Yes, I met them in March this year, if it was not April. And the board has got a CEO, and I do phone the CEO quite often. She is in Cape now presenting the reports about Office of Health Standard Compliance. If those reports, because then those are a measuring rod, if they say the healthcare system has collapsed, then I won't phone and ask anybody. If today, because they also started at 2 o'clock, when she reports to Parliament, she says, according to her findings, because that report is going to be public, you'll see it. She'll say, this is what we have measured it this way. This is what we have gauged it this way. These are the numbers we are using them this way, and these are our findings, and therefore there's a collapse. I won't phone anybody to ask questions if that happens. The issue of Mr. Stirman of SAMA, Deans, EFF, and TAC, yes, most of the issues they raised are the ones I've also raised. Remember here, I never denied that we are faced with a huge crisis because of the burden of disease. But I'm talking about total collapse. And I gave you information why I said I do not think that will be characterized by that. Yes, SAMA, I did not see any statement from them. It was a statement from Dr. Groot Boom. I was very surprised because he doesn't even work for the state. He is the president of SAMA, yes, and perhaps he hasn't got into our hospitals for quite a long time because he doesn't work in any of our hospitals. But he mentioned the issue of leaking theaters, and I said I've been searching around to find out. He mentioned the issue of drug stockouts. I've given you percentages, and the scientific system that we are using. We have got documents so that you can come and have a look at them, how the scientific system works. We've got an electronic map right here in Pretoria, where nurses scan the barcode on the, on the medicine bottles and packets, and it reflects on the light there. If the light is red, we know there's no stock out from that particular clinic. I mean, if it is green, there's no stock out. If it's red, there's stock out, we phone. And that's the instrument I was using. I'm not sure what instrument was being used when they say that drug stock outs. The deans complain specifically of 2 issues. They complain of human resources. And I've just alluded to that. I didn't deny it. And I'm saying we are busy filling those posts. Yesterday, I had a 2-hour meeting with the chairperson of all the deans in the country, that Professor Vela. Yes, Professor Martin Vela. I sat with him. We discussed this issue about shortage of staff, which is true, I've told you. While the burden of disease in Africa in infectious disease is 80%, we only have 3% of the global human resources of health, global staff is 3%, so there's no way that I'm going to sit here and deny and say the deans were not telling the truth. They are telling the truth. What is left is the government going to fill those posts? And our plan is to fill them. I've told you, especially in Gauteng, the dean's problem was especially in Gauteng and KwaZulu-Natal, and I've asked them to fill the post. Remember that 4 major functions: human resources, financial management, procurement, and maintenance of infrastructure and equipment are pure provincial functions. I do not have any legal authority over those functions. They are purely in provinces, and all I can do is to impress upon them that they must fill these posts, and they are going to fill them. Yes, I'm aware of EFF. They said they are going to concentrate on the healthcare system. Yes, we already know that. I'm in touch with TAC every time about what is happening in the healthcare system. They haven't told me, at least, of any collapse. So the issue of a crisis is not what I'm talking about here. I'm talking about a total collapse, because a collapse, a collapse happened in Northwest. We know it during the strike, that there were no healthcare services. Now, if that is described as a collapse, I do not think we do have it in all the provinces in that manner, unless a definition of a collapse is something else. That's why I was asking Professor Motsoaledi to please help me about the yardstick or the instrument or the research or the information at his disposal. And unfortunately, as I said, I don't have it. Catherine, I'm not sure why you say I'm blaming patients. I am not blaming them. I'm just saying there's a huge pattern of disease. I can't blame a person for being sick. We all know that South Africa is #1 in terms of HIV/AIDS infections. We also know that there's an explosion of diabetes, cancer, and high blood pressure. We know that. We've mentioned that some years back, and even put measures to try and reduce that explosion in the form of control on tobacco products, alcohol, diet, sugar, recently about sugar tax. We are not blaming anybody about that. We're just saying, let's reduce, this is too much. We can't carry it. Even in the National Development Plan, they state that. They say the burden of disease is too high. We must not try to treat ourselves out of this burden. We must put measures to reduce it. That's what the National Development Plan has said about the burden of disease. And you are aware that Professor Makgoba was part of that National Development Plan. And they said as far back as 2012, when they released the plan, that the burden of disease is too huge and we must work towards reducing it by 2030. It's not me who said so, and I don't think they were blaming patients. They were stating facts. And I've just told you the explosion of TB in the whole world, not only in South Africa, that even heads of states have been called to New York to talk about it. When they say so, they are not blaming patients. They are just saying, we've got an explosion of TB, which is bigger than what we expected, and let's come and talk about it and put plans. The second question, Catherine, you are saying, is it because of a high burden of disease or few doctors? It's a combination of both. There is a very high burden of disease, yes, but we do have few doctors. And that's why I'm talking about filling of posts, but I'm also confessing about the number of human resources for health in our continent and also in our country. Maybe let me stick to our country. So it's a combination of both. When you have got a huge number of people coming to healthcare facilities and you have got a fewer staff members, of course it does present a crisis. But the question is, do you present that crisis as a collapse? That is the issue I was raising, not to refuse that we have got a very big burden. The second question is about steps that we are taking to deal with this problem. I've just mentioned in Northwest and Gauteng the number of vacant crucial posts that are going to be filled recently. Northwest, as recent as this month, Gauteng, the MEC will report. The second steps we are taking is to launch campaigns to contain this huge burden. And I've told you on the 28th, we are launching a campaign to deal with HIV and AIDS and make sure that we put as many people as possible on ARVs, because when we do so, the transmission of HIV/AIDS will slow down, if not stopped altogether. I also told you that early in August we will launch a campaign against cancer, which is reminiscent of the HIV/AIDS campaign. When we announce that campaign, we are going to show you what we are doing to deal with this shortage of doctors, because a large number of them, while there's a shortage in the public sector, a large number of them are in the private sector. So in those programs, we are going to contract even private doctor patients to make, doctors, private doctors, to make sure that patients have gotten access to both. That's what we have put in the white paper on NHI, that the aim of NHI is to provide access to all health facilities and all health workers, whether they are public or private, to all the citizens. We are going to do so. For instance, in this HIV campaign we are going to launch on the 28th, we are going to decant 50,000 patients to private practitioners, to GPs, and say, please take care of these patients. The state will give you the medication, but when they are sick, in terms of HIV, they are yours. We'll pay you for your services. We'll do so. On oncology, we are going to do the same thing. We have already started in KZN. We have VETS Consortium giving us private doctors who are dealing with the backlog between themselves. They are going to deal with 450 patients per month in the oncology backlog, and they are in the private sector. When we have the machines are eventually working at Addington Hospital, we will get more people. We've even tried, as another step, to get oncologists from India, for instance, but we could not get them because they insisted that we pay them much more than we pay a specialist in oncology in South Africa. That's what they demanded, that because they are from far, if we want their help, they must be paid extra. We found it difficult to accept because we think it will cause emotional problems to our specialists who are highly trained. If they sit in the same ward, side to side with somebody who is equally qualified like them, who must then earn a higher salary simply because they come from another country. So we declined that offer. We could not carry it. I have to confess about that in terms of getting more oncologists. So we'll rather stick to our private sector oncologists. In Gauteng, with this 100 million, and we are going to do the same thing and say people in private sector must take a certain number of patients, and we're going to pay them. So these are the steps we are taking. But the final steps to end this malady, I'll outline them next week when we release the NHI bill, because it still has to go to cabinet tomorrow. And I can't stop talking about what is there because we don't know whether the cabinet will finally approve it. But once they approve it, we'll call a press conference, and all these things which are problems are outlined. Whether I'm the right person for the job or not, I leave it to your judgment. I can't sit here and say, yes, I'm right and all that. I gave my account, even to Life is Dimeni, to Judge Museneke, and he made his own judgment about what has happened. You can go and look at it. The SIU has given an interim report about their findings as to who is going to be charged, who did that. I'm sure when that report comes, you'll see where they place me, because we said they must investigate each and every aspect and tell us who is wrong, who's going to be charged. The SIU is doing that, so I cannot stand here and make a judgment for myself. Professor Malga Purumakhoba has written that report about his findings. You can go and check what he has said about me. So I find it very difficult to answer that question, that talk about myself personally and directly. I'll leave it over to you. Thank you.
Thank you, Minister. Before I take the follow-up questions, I'm going to check questions from Cape Town. Andile?
Yes, we do have a question. Over to you, Yanan.
Yeah, can we?
Thank you, Yanan, for Pretoria FM. 3 questions, Minister. You know, you're talking about the solution of the oncology crisis, for instance, in my former home province of KZN. What gets me, just on a realistic level, is the time that this has taken to solve, and just the pathetic nature of it. The fact that clearly the KZN Department of Health did not do its job. How is it possible? How is it even imaginable that in a city like Durban, such a situation can exist where actually management was just pathetic, and who's going to be held to account and how, both professionally and politically? And how will a repetition be avoided? Secondly, our government has, and you've just referred to it, as its center point, this NHI, which will expect much more of the health system than is currently required. Yesterday, we had an excellent briefing from for a government institution, rather high-level grouping called the Financial and Fiscal Commission, where they said what everybody has said and what this government is not listening to, which is you must cost stuff and then you must know whether you have the ability to do it. If government does not have the ability to run the present health system in any satisfactory way, for any number of reasons, including, for instance, overburdening, how on God's earth are you going to realistically and responsibly say that you're going to be able to implement the NHI in anything but the disastrous way in which health systems, by your own admission, is being implemented currently? And finally, much of the blame you shift onto foreign students and foreign patients. The numbers you've given are quite astounding, that in some hospitals, the vast majority of babies born are foreign to South Africa. Now, obviously, politically, that's a sensitive point, but realistically, it says that the cash burden is enormous on the South African taxpayer, who surely cannot be expected to realistically foot the bill continuously for everybody from outside the country. What is the solution?
Back to you, that's all.
Okay. Yes, the oncology crisis was quite bad. You are right. And we don't like what KZN has done. I carry the brand by virtue of being a minister because of procurement issues and human resource issues that happened in KZN. I do accept that. But we are trying to help them, as I've said. For instance, we have even bought them a new oncology equipment, which has arrived from overseas. It has been installed, and it's busy being tested, whether it will start functioning. We have done that. We've even helped to repair the previous one. The issue as to who must account for that, we will leave that to the Human Rights Commission, because they are the ones who are investigating what led to that state of affairs in KZN. And I'm sure they are about to release their final report about that. But I do accept that the issues that led to that oncology problem are something that is unacceptable, and it was very disappointing. Now, the issue of NHI, I was trying to avoid it and what we are solving, because I'm going to spend at least 3 hours with you on NHI, including what the Finance and Fiscal Commission is saying, because I did meet them about NHI, that there must be costing of staff, etc., which is correct. In the NHI white paper, it's like that, and you'll see how we put it in the bill itself. But there's something here very curious. NHI is a way to achieve universal health coverage. And the reason to achieve universal health coverage, or UHC, is something that the United Nations adopted in 2015 as part of the 17 Sustainable Development Goals. They say goal number 3.8 is universal health coverage. And they said the Sustainable Development Goals are there to take the world to another level of development. Without them, the world cannot develop. Now, if you look at goal number 3.8, which talks about universal health coverage, they are doing it because there are problems in healthcare around the world. We are doing NHI for the same reason. There are problems in healthcare. If there were no problems, we won't need NHI, believe you me. We won't believe NHI. It's not a luxury. It's an instrument to solve problem of access, of equality, of bringing equality. Because there is so much gross inequality in healthcare in South Africa. Problems of management, and problem of skill, and problem of human resources. And the determination to do that was brought by the United Nations. Even the document written by the elders who were put up by Madiba, who were chaired by Kofi Annan, mentioned that they brought economists, 247 of them signed the declaration, and they were from 44 countries, which said there are health and economic benefits of putting up NHI. We wouldn't build it, believe you me, if there was no problem. Why? Why should you put a system like that if your healthcare system is running very well? You do it very much for the simple reason that your health system is not doing well. The first country to come with this system was the UK, 70 years ago, in 1948. They did not do it because things were going all in England and they were running their healthcare system very well. No, they did it because it was 3 years after the Second World War. The British were poor. Their healthcare system was in tatters. They were very much unemployed. They were very sick, having just been scarred by war. And they said we need a system of universal health coverage, which they called NHS. They did not implement it because their health system was doing well. Otherwise, they would not have needed it. When President Barack Obama came with Obamacare, which is the universal health coverage for America, he did it because in the present American healthcare system, about 22 million Americans cannot afford good quality healthcare. They were out of the system, and he said we need a universal health system called Obamacare. When it was introduced in Mexico in 2001, it was called Seguro Popular, meaning a popular scheme for everybody. The professor who put it up eventually went to become the head of public health at Harvard University. I had an opportunity of being lectured by him on several occasions. And when he gave reasons why they had to launch it, it was not because they were running the healthcare system very well. It was actually the opposite, that when a healthcare system doesn't go well, because of the problems that I've mentioned, you actually implement a system of universal health. When you go to Japan in 1961, those who are old enough, when they launched the system, it was because Japan was in tatters, having been ravaged by the Second World War, the Hiroshima bomb and the Nagasaki bomb, and they launched a universal health coverage system, which they are still very proud of. So each and every country on the planet, when they launched this system, is because there were problems. Three or 4 years ago, when we were at the World Health Assembly in Geneva,